Wow, amazing. So hello to everyone. I'm very, very happy to be here today. I want to thank to the scientific committee for this invitation to this amazing event. And I want to start just by presenting a case to you. And she's Liliana. She's a patient that you could have treated in your own clinic. And she came with this situation. In my perspective, this is a very complex situation. And I would say that the first thing that comes to our minds is how or where to start planning this case. So before planning, I think that there is a word that we are not using too much now, that is diagnosis. And if we don't have a good diagnosis, it's very difficult for us to have a good planning and then to render the proper treatment for the patient. So in 2017, we published this workflow that basically describes how to plan or how to diagnose and then plan a complex treatment case based on digital technologies. And today, based on the tools that we have from Straumann, I think that we can combine all this information in a digital environment that is going to give us a lot of benefits in terms of the planning process and also the way we are going to try to accomplish the treatment that we are proposing to our patient. So for example, in here, I'm using two different platforms. One is it's a website-based platform that is MyCloud, just to propose an AI-based treatment to our patient. And at the same time, I'm working with Co-Diagnostics, that is a software that probably most of you already know, just to plan where the future implants are going to be placed. So the idea in here, and as you can see here, the before or after, is just to be very, very non-invasive and to try to accomplish a very good result, most of all by maintaining and reconstructing the tissues that were lost during the patient's life. And for me, this is a very beautiful picture because it shows exactly what we are trying to do in here. Try to maintain and mimic nature the best way possible. And this is something that takes time. And that's why, for me, FP1 probably is the most difficult treatment for an edentulous patient or a patient with a terminal dentition. So why digital? Well, going digital is going to give us a lot of information, probably more than information than the one that we are going to get from a conventional way. And it's going to give us options. And we are going to have these options available to transfer to our patient treatment. So you can see how we started with Liliana and how we finished with her. And again, this is just an introductory case, but this is just to show you how we can use these technologies to achieve this type of treatment. And today I'm going to focus most of all on FP1 treatments because, again, I consider that this is the most difficult treatment for an edentulous case. And I want you to understand also that this concept of reducing bone to try to get restorative space is something that probably was used in the past, but today, based on the technologies that we have and also the type of materials that we're using, we don't need it anymore. If the patient had it before, it means that we have the restorative space. So we don't need to reduce bone. I would say we have a couple of situations that maybe it's necessary, but most of the times we don't need to do it. But for an FP1, it's very important to have a very good diagnosis to understand why the patient came into this situation, a very good planning, a very good implant distribution, and taking in consideration that if the implant is not in the right position, we are probably disturb the papillas between these pontics, and maybe we are going to destroy the aesthetic result of our case. Bone maintenance or reconstruction, as I was saying, we don't need to reduce bone anymore. And time, soft tissue management and time. If we really respect biology and we give time and we work with our provisional restorations, we are going to get very good results, but we need to be patient, okay? So I'm going to start just by showing you a case that we did in the Advanced Graduate Education Program in Implant Dentistry, where I serve as a director with Dr. Nassau and Dr. Samakondi, that is here in the auditorium. And I want you to present Richard. Richard came with several issues in his mouth. And after a restorative diagnosis and analysis, and also periodontal analysis, we decided that we were going to extract all the teeth and go with full arches restorations. Now, I like to save teeth. I think that as a dentist, we should save teeth all we can, because there is this trend that just let's try to extract everything and do full arches. I don't think this is an appropriate approach. But when it's necessary, we need to use the appropriate tools to get the best results as possible. So in this particular case, instead of going with an immediate implant placement, we decided to wait and to do CAD/CAM dentures, just to understand a little bit how the tissues were going to retract and where the implants were going to be placed. And this is, again, very important because we're thinking to do an FP1. If the implants are not in the right position, probably I'm going to create a problem. So once we have stabilized the patient's occlusion and we know exactly where the implants are going to be placed, we're going to go forward with what is called the dual scan protocol, something that was published more than 25 years ago, or around 25 years ago, by Steinberg. And we're still using this protocol. So basically, we take the first CVCT of the patient using or wearing the dentures or the radiographic templates, and then a second CVCT just of the templates. Since these templates, they have radiographic markers, we're going to be able to superimpose this information in a software. And from there, we're going to be able to plan exactly where we want to place our implants in a very precise way. Now, one of the things that, from my perspective, is very interesting is that based on this concept of Smile Box, we can just work with a third party, in this case Straumann, just to plan exactly where we're going to place our implants, and they are going to be able to design and print the surgical guides that we're going to use, not only for the implant placement, but also to place the provisional restorations at the same time in an immediate loading fashion for the mandible and for the maximal at the same time. So this is what we get from Straumann in a very beautiful white box, and we're ready now to go to our surgical procedure. So you can see here that we are going under a flapless approach because we have the requisites to go under a flapless approach. Again, static computer-guided implant surgery doesn't mean flapless approach, but when the conditions are the right ones, it's a very good way to do it. And you can see how the implants were placed in a very beautiful way, in a very non-invasive way, and we were able to immediately load them at the same day. And now I think it's the right time to wait, to work on our provisionals, to add a little bit of resin or acrylic or another type of material in certain areas, or to polish a little bit, to give space for the soft tissues, or compress in certain areas, because these soft tissues are going to react to this prosthetically driven soft tissue conditioning process that we are doing. And this is extremely important. And I always talk to my residents and I say, let's wait. Sometimes we wait a lot of time with provisionals, or we change these provisionals for a new set of ones until we have the desired result to move forward to the definitive impression. And in here, I want just to stop for a second because I believe that there's a concept that I learned from my boss at the school, Dr. Herman Gallucci. We cannot separate anymore the prosthetic components and the abutments from the implants, okay? We need to consider them as a whole concept, because the prosthetics or the prosthesis can affect the biology or the result of the response of the bone. So that's why I think that this connection that is called TorqueFit and this IXL concept that Straumann is very interesting, because we're going to maintain the same shape and design of the abutments during the whole process. So we are going to avoid this bone remodeling process that occurs when you are exchanging different sizes and designs of abutments. Once you have already obtained the profile that you want to obtain, you are ready to move forward with the digital impressions or conventional impressions. And Dr. Papaspiridakos already described a lot about the concept. But basically, the idea here is to transfer all this information from the provisionals to the lab. occlusion, aesthetics, phonetics, etc. They are going to work now with these prototypes to deliver the definitive restorations. And in fact, we can add even more information based on the use of Mojo, for example. That is a tracking device that is going to give us a lot of information on how the mandible is going to move. So in this case, we decided to move forward with these segmented structures for different bridges in the maxilla and a full arch in the lower. And you can see how we went from the model to the mouth, and same thing for the mandible, in a very straightforward manner. Again, it takes time, most of all because you want to condition the soft tissues to get a very good aesthetic result. And you can see also how the implants were distributed, and this is based on the treatment guide 4 that was also published in 2010. But the most interesting thing in here is that we were able to replicate the whole planning from the tracking device to the definitive restorations. And we were able to achieve exactly the same type of occlusion that was designed in the computer before. Now, what happens when we have a more complex situation? And this case was published in the treatment guide 11, so if you take the photo of the QR code, you're going to be able to go there and see the full case. This is Andrea, very nice patient, but you can see that she has a lot of problems in her mouth. And if I show you the intraoral photos, you're going to see that what I'm saying is true. She has been under different treatments during her life, and I could say that most of them had failed, probably because of the wrong diagnosis. Now, what is important in this case, besides the fact that the aesthetic situation and the function is not good, is that she's presenting a lot of pain at the TMJ level and also at the muscle levels because of the collapse of the bite. So her vertical dimension is diminished because of the lack of support. So we need to start understanding and planning how we are going to restore that occlusion before we place our implants. Because the first thing that we can say is, we're going to extract, we're going to place implants, immediate loading, that's it. But we know that this is not going to be predictable in time. So following the same process, we're going to start by doing the data acquisition process. The more information we get, the better the result that we are going to have. And again, we need to start by stabilizing the occlusion in here. So as dentists, and I said this before, I like to save teeth, most of all because of the proprioception that the periodontal ligament can give us. And I decided to save this teeth at the group 5 with an adhesive solution, and to create or fabricate an immediate denture for the maxilla, just to stabilize the occlusion and try to get rid of this pain that the patient is having during all this time. We transferred this information from this wax up to her mouth through a mock-up, and now we are ready to move forward with the maxilla. In the maxilla, we decided to do the extractions, ridge preservation using an FDBA and collagen plugs, and now is the time to wait until everything is healed. Why not to place the implant immediately? Because I'm not sure where the implant should be placed. It's not that I don't want, it's just that I need to have more information. And this information is going to come from this denture that I'm creating right now, that is going to serve as a prototype to understand where the implant should be placed. And here you can see, after 20 days, how she is looking. You are going to see that she's moving her lip, trying to maintain the denture in position, but the pain is not there anymore. And this is something that is giving me a lot of information. The vertical dimension of the occlusion is in the right situation right now. In fact, we can measure that through a cephalometric analysis. And we can check that all the angles that in some way give us information about the vertical dimension are in the right parameters. So now, since everything is stable, we are ready to move forward to the planning phase of our implant. And again, we are going to go through this dual scan protocol, taking the first scanner with the patient using the dentures or the radiographic templates, then a second one only for the radiographic templates, and then we're going to import this information to a software where we are going to be able just to plan the whole process. We are ready to print our guides. We did this flapless implant placement in the lower mandible. You can see that we are maintaining this mock-up in the anterior teeth just to maintain this vertical dimension. And now we are moving forward to the maxilla. You can take a photo of this QR code because we published this technique a few years ago, and you're going to be able to read this article. But basically, what we were trying to do in here is to move the boundaries a little bit more. We were trying to do something different, and this was to try to have a prefabricated restoration that is going to go directly to the abutments without the need of picking up the abutments. This is something that is a little bit complex because we know that computer-guided implant surgery, it has distortion. But we need to be, or to try to be very precise to be able to work with this technique. So basically what we're doing here, we are subtracting the information from the implants from this model. Basically, we're creating this master model before implant placement. And using this information from the patient's face, plus the information from the denture and the information from the master model, if we combine this information and move it to the digital environment, the lab is going to be able to prefabricate this PMMA FP1 before implant placement. So now we're ready to move to the surgical procedure. So as you can see here, we are going through a flapless approach because the conditions are the right ones. And you can see how we move from the pre-surgical situation to the surgical or post-surgical situation where we placed the abutments that were selected in the computer before the surgery. And now, after the abutments were placed, I'm just placing the full arch restoration or almost full arch restoration in position. I wouldn't say that it was completely passive because I would be lying, but it was very, very close. And since this is a provisional restoration in PMMA, these implants are going to be able to tolerate a little bit this micro tension. I did a small connective tissue grafting just to increase the thickness of the phenotype at that side, just to have a better phenotype to start recontouring. And you can see after 35 minutes how the patient looks, most of all because this was a flapless procedure. 24 hours later, we follow up her. You can see the x-ray. And you can see how she feels. She's talking in a very nice way. She feels very good. Most of all because we're replicating what we planned at the beginning of the process. The occlusion is stable, and now she's feeling very good. No pain anymore at the muscles or the TMJs. And now is the time to start working with the provisional. So we're going to start recontouring this provisional, just adding resin or acrylic in certain areas. We're going to start polishing and giving space for these soft tissues to go in between the pontics and create these pseudo papillas, because remember that we don't have bone in between, until we have the desired profile to move forward with the definitive restoration. So when we are ready, the only thing that we need to do now is copy, paste. That's why it's so important to have a good planning from the beginning. And what we're doing in here is we are transferring this information from the initial situation to the digital environment and then to the definitive restorations that in this case are monolithic structures. So we don't need a model either. Everything is done in the computer, then this structure is milled, and then we're ready to place it in the patient's mouth. Since we are trying to maintain the vertical dimension, now we are ready to go with the anterior segment. And in here, I decided to change the material just to have a better aesthetic result. And the reason I'm showing you these images is because, as Panos was saying before, these technologies are not a replacement for conventional dentistry. This is a vehicle. This is something that is going to help us, but it's not going to change dentistry. So if we cannot see with our eyes the margin of the preparation, the scanner is not going to see it either. So it's very important to have good isolation and use the proper technique for impressions. Now we're ready to move forward with the upper restoration. So this prototype that was maintaining the soft tissues in position, now we need to copy it send it back to the lab in a digital way, so they're going to be able to modify it if we need it or not, and then deliver a PMMA prototype that is the definitive proposal that we are going to identify as the definitive result. So here we're going to check the occlusion, we're going to check the static result, and if we want to modify it, it's very simple. We just do it, and then we scan it again. Or if everything is good, we can move forward with the definitive material. That in this case is zirconia with a very small cutback at the buccal surface where the lab is going to layer IMAX porcelain just to have a more aesthetic result. So then we're ready to move to the day of the delivery with these zirconia structures. And you can see how the before and after was achieved. In fact, we decided to move forward with a CAD-CAM night guard just to protect everything. And there's something that I consider that is also very interesting. Since we are working with cephalometric analysis just to be sure that we are in the right positions, today we can work with artificial intelligence-assisted cephalometric analysis in a website. So we can check and define the difference in the vertical dimension in a very simple way, very fast, just to check that the result that we were looking for is the right one. 4 years later, you are going to see here the follow-up. The soft tissues look a little bit red because I did the mistake to take the photos after the cleaning. But trust me, everything is very stable. And again, we are following a distribution of the implants that is described in the evidence as a very predictable one, most of all because of the shape of the arch of the patient. So again, you are going to see here Andrea at the beginning and how we finish this treatment in a very predictable way. And this is something that we usually do. This is what we call the quality check. Basically, the idea here is to be able to understand that if what we propose as a treatment was accomplished or not. It's not because I want to show off what we do. It's because this is something that is very interesting from a facial standpoint of the oral rehabilitation process. So as a conclusions, first, I would like to say that the more information we can collect during our diagnosis, the better planning and better result we're going to get. The comprehensive approach in here is fundamental, and these technologies are going to help us a lot to communicate between the different members of the team we are working on. Try to leverage on these technologies. They're going to help us a lot. But as Dr. Papaspiridakos was saying before, this is not going to save us. Okay? This is not a replacement. This is just a different way to do things. And respect biology. If we take time and we are respectful with biology, these results are going to come very easily. And all of this is going to help us to maximize our results and, of course, to optimize patient treatment outcomes. So with this, I want to thank you for your attention. I want to thank also to Harvard School of Dental Medicine, my house. I want to thank my residents and the RDBS department and Advanced Graduate Implant Program at Harvard School of Dental Medicine. Thank you very much for your attention.